Hello, my name is Niki Chouliara and I'm a research fellow at the University of Nottingham. Thank you for joining me for this presentation, which will focus on our research on stroke early supported discharge services and our efforts to understand what drives the implementation of these services in real-world settings and what is the role of the context. We know that stroke specialist rehabilitation has the potential to promote recovery and improve outcomes in stroke survivors. In England, the NHS long-term plan has highlighted the need for improved post-hospital rehabilitation service models. One such model is early supported discharge, which involves the coordinated transfer of care from hospital to the patient's home to provide timely and specialist rehabilitation by a multidisciplinary team of professionals. Driven by a strong evidence base on the benefits of the intervention, stroke care guidelines in England and abroad recommend the provision of ESD as part of an evidence-based stroke care pathway. Core components of effective ESD have been identified, including the provision of responsive and intensive rehabilitation by a coordinated multidisciplinary team. Although the importance of these components has been demonstrated in clinical trials, it remains unclear whether and how they are achieved in clinical practice, which was what the larger WISE project this study was part of set out to investigate. In England, the National Stroke Audit Programme showed that the provision of ESD is variable and may differ from evidence-based models. The observed variability in ESD models may reflect attempts to tailor the intervention to local conditions, highlighting the need to understand the key contextual influences these services are exposed to. Given that ESD is delivered to patients in their own home, necessitating the delivery of rehabilitation over potentially large rural geographical areas, the influence of the service's geographical location is of particular interest. With most of the original trials conducted in urban settings, questions are raised regarding how ESD schemes might operate in dispersed rural communities. This study set out to investigate the influence of rural geography on the implementation of evidence-based ESD schemes, with a view to informing improvements in service provision. The wider WISE research study followed a mixed method realist evaluation approach. Realist evaluation seeks to develop, test, and refine theories that explain how healthcare programs work and why they are successful in certain conditions and not in others. The building blocks of program theories are CMO configurations or hypotheses about how contextual factors interact with underlying mechanisms to generate intended or unintended outcomes. In developing our preliminary CMOs, we found it helpful to define mechanisms as an interaction between the resources offered by the intervention and stakeholders' reasoning and responses to these resources. We conceptualized evidence-based core components of ESD services to be the program resources, and we explored how staff members perceived and acted upon these components, and how this interaction influenced the provision of a responsive and intensive service. Our exploration of context was informed by a rapid evidence synthesis, which we conducted to identify contextual determinants facilitating or impeding the implementation of home-based stroke rehabilitation. And today, as I mentioned, we are focusing on geography as the key contextual influence of interest. The framework I just presented underpinned the development of three overarching program theories that led the inquiry of the wider project. The second program theory suggested that core components of ESD will operate differently in urban and rural settings, and is the theory that we tested in this study. 6 case study sites were selected based on a purposive sampling approach aiming to capture variation in terms of the model of ESD service and the level of rurality. We interviewed, either through one-to-one or group interviews, 117 ESD staff participants, including clinicians, service leads, managers and commissioners. The analysis was guided by our overarching theoretical framework and followed an iterative process which involved identifying CMO chains, first at the participant and then at a site level, so we could look at differences and commonalities across sites. This slide presents two CMOs which were common across sites, regardless of their geographical location. They related to the adoption of certain core components and how they help the teams achieve intensive and responsive practice. Just a note to help you read these figures that positive outcomes are depicted in green boxes and negative or unintended outcomes are in pink. Respondents agreed that the challenges of community working, such as travel times, called for interdisciplinary working and blurring of professional divides to provide intensive rehabilitation inputs in an efficient way. In addition to promoting teamwork and collegiality, developing an interdisciplinary skill set enables staff members to coordinate effectively and work flexibly across professional boundaries to best respond to patients' needs. The term neurapists was introduced by one team to describe their nurses and therapists' shared skill sets and approach to rehabilitation. Participants' accounts further highlighted the importance of good multidisciplinary teamwork as a core component of a successful ESD service. Regular MDT meetings with good attendance were thought to remediate breakdowns in team communication caused by increased workload and traveling. Despite the challenges of getting everyone physically together, especially in times of high pressure, all teams agreed on the importance of safeguarding regular face-to-face meetings as essential to achieving clear communication between staff members. Respondents identified the time required to travel to their patients as an important element of context, which could influence the number of patients they could see in a day and the intensity of rehabilitation they could offer. The impact was more pronounced in services covering rural or large catchment areas, where teams spent a big part of their day on the road, leaving less time for active rehabilitation. In rural areas, further delays were caused by poor road infrastructure and poor connectivity for mobile phones and satellite navigation systems. To ensure that patients living remotely did not receive a lesser service, these teams spread the number of visits evenly across their patients. When capacity was stretched, however, they also had to extend the length of the service to allow patients the time to achieve benefits before discharge. This in turn had a knock-on effect on service capacity and on the flow of new patients from the hospital. Teams adjusted the way that their MDTs were organized and operated to mitigate the impact of traveling on the operation of their services. Teams covering large or rural areas organized patients geographically, and some of them implemented patchworking, which involved dividing their MDTs into sub-teams that covered different geographical areas. Sub-teams would work flexibly to keep caseloads evenly spread and allocate resources where they were most needed, a strategy thought to maximize capacity and improve responsiveness. In one site, the MDT was split into 5 sub-teams. It was envisaged that this would ensure that patients across the catchment area had equal access to senior therapists. Separate patch meetings were also introduced to make the best use of staff's time, reducing the length of the weekly MDT meetings. This process was thought to encourage communication between staff members and allowed sub-teams to discuss cases in more detail. Good planning and coordination between team members was seen as key in addressing challenges posed by geography. In addition to adjusting MDT structures, services covering rural or large areas implemented sophisticated timetabling systems. The complexity of these systems, however, made it harder for clinicians to adjust their schedules to patients' fast-changing needs. For instance, arranging short but more frequent visits to manage patients' fatigue proved a challenge for patients living remotely. It was also suggested that patients living closer to the service might benefit from cancellations and opportunistic visits, or even experience a more responsive service. One team explained that when capacity was low and patients had to be put on a waiting list, patients living closer to the location of staff members would be prioritized once a slot became available. To conclude, our analysis unveiled subtle but important differences between urban and rural settings, supporting our initial program theory. We uncovered examples of how operating in rural settings could influence the intensity of rehabilitation provision and teams' flexibility to adjust the frequency and duration of the visits to people's needs. Though the impact was more prominent in rural services, those covering large catchment areas were also affected, suggesting that we may need to distinguish between remoteness and rurality to disentangle the influence of geography. Services covering rural or large catchment areas appeared more sensitive to capacity fluctuations, stressing the need to ensure appropriate staffing levels for the smooth operation of these services. Despite variations in the wider service model of operation and geographical location, the adoption of core components of ESD, such as coordinated multidisciplinary working, helped teams manage the pressures and deliver services that met evidence-based standards. This could be interpreted to say that the effects of adopting core components were similar for both rural and urban services. The realist evaluation methodology allowed us to address the complexity of ESD delivery in clinical practice and obtain a better understanding of how staff responded to the influence of geography in order to achieve a responsive and intensive service. Our findings reflect Dan Schroeder's conceptualization of a complex intervention as consisting of core active ingredients and an adaptable periphery. For instance, services safeguarded their MDT meetings but adjusted the way that their MDT was organized to reduce travel time and use resources efficiently. Distinguishing between elements of the intervention that need to be protected and elements that can be modified to account for contextual influences allowed us to draw transferable lessons that could inform customization efforts aimed at maximizing success of community-based stroke rehab services in different geographical contexts. I have included some key references you may find useful. Thank you to the team and thank you for listening. We'd love to hear from you, so please do get in touch.